The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series. My name is Shanna McKernan, and today I'm interviewing Dr. Nancy Davidson from the Fred Hutchinson Cancer Research Center and University of Washington, an author on systemic therapy for patients with advanced human epidermal growth factor receptor 2 positive breast cancer, American Society of Clinical Oncology Clinical Practice Guideline Update. Thank you for being here today, Dr. Davidson.
Thank you for the opportunity.
So first, can you give us a general overview of what this guideline covers?
This guideline is directed specifically at the use of systemic therapy, especially the anti-HER2 therapies for patients who have advanced HER2-positive breast cancer from the time of diagnosis of advanced disease through multiple settings. It is not a guideline for women who have early-stage breast cancer, where we would think about treatment in the adjuvant setting.
And what are the key recommendations of this guideline?
This guideline looked at a couple of really important questions for clinicians. One question is it looked at the optimal treatment for women or men who have HER2-positive breast cancer, advanced breast cancer at various stages, first line, second line, third line. The second is it helped us to think about if you're going to give that therapy, what are the regimens that you might continue? What's the evidence behind that? And third, it helped us to think a lot about the timing and the duration of these therapies. How long would you take them forward? So if you think about the first question is, what is the optimal treatment for patients who have HER2-positive advanced breast cancer? And particularly, clinicians might wonder, does every single patient with that kind of breast cancer need an anti-HER2 therapy? I think we felt pretty strongly that in the first-line setting, that most women or men would be candidates for that therapy. There might be circumstances where a patient has an estrogen or progesterone receptor-positive tumor, which is also HER2 positive, and where one might make the decision to give only hormone therapy at that point. But for most patients, we would envision that anti-HER2 therapy of some sort would be part of their treatment in first line and in second line and in third line metastatic breast cancer. And we think the evidence that supports this is by and large quite strong. So patients in this setting are going to be on some kind of anti-HER2 therapy for quite some time. The second question we thought about is, given the fact that there are several anti-HER2 therapies, which would be the best ones to use in each of these settings? We felt that the evidence is very strong that in the first line setting, clinicians should recommend a combination of trastuzumab, pertuzumab, and a taxane, unless the patient shouldn't take the taxanes. And then, assuming that patients got that therapy in the second line setting, we felt that it might be rational to change them to the TDM1 therapy. And then finally, in the third line, when patients progress, we thought that it might be appropriate to make sure that they had gotten all the drugs that we've already talked about. And if they are still in need of therapy, that one could think about some sort of treatment that involves the drug lopatinib in combination, perhaps with other chemotherapeutic agents. So this suggests that consistent chronic anti-HER2 therapy is going to be part of the landscape for treatment for women with metastatic breast cancer across all lines of therapy. The second question was, how long would you do it? And I just covered that by and large, we would be imagining that we would continue the anti-HER2 therapy pretty much indefinitely. Lastly, one might wonder whether or not our recommendations would change if the patient had already had trastuzumab in the adjuvant setting. And if it's a short period of time between when that finished and when the patient relapses, then we would suggest that clinicians would think about those patients as requiring second-line HER2-based therapy. If it's been more than a year, then we would think that we should think of that as first-line therapy and go to that trastuzumab, pertuzumab, taxane combination. So that covers the anti-HER2 therapies. I think it's important to realize that many of these women may also have estrogen and progesterone positive disease. And of course, we may wish in some cases to use the anti-HER2 therapy with chemotherapy alone, or perhaps use endocrine therapy with anti-HER2 therapy, or in rare cases, as we talked about, use endocrine therapy alone. So we should be thinking about these two types of targeted therapy, both separately and then together.
And since these guideline recommendations are consistent with the 2014 version, this signals that there's a lack of practice-changing data in this area. So how does that inform future research?
I think that's true, that there is no change in practice at the present time. This is only a couple of years ago that we're looking at our update between 2014 and the present. So I think this partly reflects the fact that we have a lot of really good anti-HER2 choices that we can use and sequence for patients. And so in some ways, this reflects the benefits of the research that we've done in the past. I think the key issues going forward are going to reflect in part whether there are ways that we can do a better job of predicting who should get what when, sort of the whole idea of predictive factors. Whether in all cases we have to give the chemotherapy, whether there are any other new anti-HER2 agents that might come on board, and whether we can get a better sense on resistance. Finally, we always pay attention to the toxicity parts of this. So all of these things, I think, are going to be part of our future research. But I would be looking at this as a wonderful example of where great science has helped us to develop a number of effective agents. And we have the fortune now of being able to think about how to sequence them going forward. The other area, which is a very hot topic for research and which is covered in the context of a sister guideline, has to do with the fact that many of these patients will have their recurrence in the setting of the brain with brain metastasis. And so that's a very active area of research as well, this sanctuary site and how we think about that and how we might try to reduce the possibility that this would happen or to provide appropriate treatment.
And finally, how do these guideline recommendations affect patients?
I think these guideline recommendations affect patients every single day. I think that they allow us as clinicians to work with patients to make the best evidence-based decisions for their particular situation with their disease. They provide recommendations about how you might be able to sequence therapies effectively in order to provide effective disease palliation with minimal toxicity over long periods of time. So I would hope that patients would take away from this great reassurance that there's been a tremendous amount of research that's been done in this field, and we now have really good medical evidence that allows us to guide treatment recommendations over the spectrum of metastatic breast cancer.
Great. Thank you for your work on this important guideline, and thank you for your time today, Dr. Davidson.
Thanks very much for the chance to talk about the findings from our guideline and the opportunities that we have available for patients with metastatic breast cancer with HER2-positive disease.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer the show to a colleague.